All right, everybody. This is Linsea Ford. I'm a PGY3. Going to be talking to you a little bit today about the Pioneer 6 trial. So this was a cardiovascular outcome trial done on oral semaglutide. And if you're like me and you didn't even know that there was such a thing as an oral GLP-1, this will be kind of interesting because before I was assigned this, I didn't actually know that we'd recently had one FDA approved. So let's get started. Just a little bit of the outline of my presentation, pretty standard for Journal Club. We'll go through a little bit of the background, some of the methods used, the outcomes chosen, statistical analysis, the results, and then we'll discuss a little bit about what the results mean to us as clinicians, and then a little bit about some of the lessons we can learn about evidence-based medicine from this presentation. So just a little bit about diabetes type 2 on the whole. This is something that's very common. We see patients in clinic and in the hospital every single day with diabetes. Greater than 34 million people in the United States have diabetes, and about 20% don't even know they have it. As far as people with prediabetes, or what we like to refer to as insulin resistance, almost 80% of people with this condition are unaware. So this is certainly something that's extremely relevant to our clinical practice as internists. Some of the thoughts about kind of the increase in diabetes that we're seeing seem to be correlating with both the advancing population age and particularly the increase in patients who are overweight and obese. So we were all taught in med school, diabetes causes both macrovascular and microvascular disease. Microvascular being the retinopathy, nephropathy, neuropathy, macrovascular being atherosclerosis that we see that leads to coronary disease, peripheral arterial disease, cerebrovascular disease, things like that. The important thing to keep in mind is that cardiovascular disease remains the #1 cause of death in patients who have diabetes. So anything we can do to potentially, reduce their risk of cardiovascular disease is certainly worthwhile. So something else that I think we were all probably taught going through med school is that really keeping tight glucose control, or controlling someone's hemoglobin A1C, getting that down below goal, is vitally important to improve their outcomes in terms of microvascular disease. So remember, that's the chronic kidney disease, diabetic retinopathy, diabetic neuropathy, and all of those things. But that glucose control in and of itself does not do anything to change the patient's macrovascular risk. So you can have somebody very well controlled with a hemoglobin A1C of 6.4, and because of the nature of how diabetes works, they're still going to be at risk for macrovascular disease. And something that was actually found, there were several meta-analyses and then a few other actual RCTs done around 2007, showing us that one class of diabetes medicines in particular, I don't even know how to pronounce the actual class name, I've yet to learn it, but the medications are like pioglitazone or Actos and rosiglitazone, actually demonstrated an increased risk in cardiovascular disease, particularly with CHF, and some studies even showed an increased risk of cardiac death. So these studies coming out actually kind of prompted the FDA to take a closer look at diabetes medicines and say, these medicines may be great to lower the blood sugar, but are they causing an increased risk of cardiovascular diseases in the patients that take them? So there was a mandate put out in 2008 that all new glucose lowering therapies, so any new diabetes medicine, had to undergo a clinical trial specifically to evaluate the cardiac safety of those medications. And kind of the way they defined it, that is that they can't pose an unacceptable increase in a patient's cardiovascular risk. So what that looks like statistically is the upper limit of that 95% confidence interval for a major adverse cardiac event could not exceed 1.8. which is actually an 80% increase in cardiovascular risk, which is quite a bit. That's a pretty low bar that they have to meet. But that's why we're seeing more and more of these cardiovascular outcome trials come out that are kind of, some of which are showing us that these meds may have benefit that we previously didn't think would be possible, strictly with glucose control. So I've kind of listed here just some of these common trials that we've seen broken up into the classes of diabetes medicines. The DPP4s, each of these have been tested in a cardiovascular safety trial. They cleared the bar, saying that they don't increase any adverse cardiovascular events, they don't increase mortality, but we also didn't see really any signal of cardiovascular or mortality benefit with these drugs. The first one really that came out showing that, hey, maybe some of these new diabetes drugs can improve cardiovascular outcomes was really empagliflozin or Jardiance. And this is still fairly new. I think this started becoming more known really when us third year started residency. And basically what that trial showed was in their composite primary outcome of cardiovascular death, non-fatal MI or non-fatal stroke, patients who took Jardiance had significantly lower rates of death. There weren't really major differences in MI or CVA, but significantly lower rates of cardiovascular death. It also significantly reduced heart failure hospitalizations. The Canvas trial that tested canagliflozin or Invokana showed similar results to this. So that's why we so often are reaching for that SGLT2 as maybe second line after metformin in patients with or at high risk for cardiovascular disease. So what about the GLP-1s? As most of us know, these medicines activate the patient's endogenous GLP-1 receptor, promoting insulin release, inhibiting glucagon secretion, and delaying gastric emptying. They are once weekly or once daily injectables up until the oral medicine that we're about to talk about came out. The major side effects that we see with this medication are obviously gastrointestinal intolerance, because you're delaying gastric emptying, particularly with a patient who may already have gastroparesis. They a lot of times can have significant nausea with this. Also, the fact that it's an injectable usually, is a barrier for some patients who are needle phobic or who associate that with insulin use and don't want to use an injectable medication. This is kind of a really busy slide and a busy chart, but basically this just kind of goes through some of the trial characteristics of the cardiovascular outcome trials done on the sub-Q GLP-1s. And something that's kind of interesting is that the SGLT2s seem to have almost a class effect with their improvement in cardiovascular outcomes, whereas the GLPs are a little bit different. Liraglutide or Victoza is the only one that currently has an indication for reduction in cardiovascular death or reduction in major cardiovascular events. The rest of the trials have all kind of had mixed results. Some of them maybe reducing mortality, some of them reducing stroke only and not MI. So it's kind of interesting to see that while we may have a class effect in one type, really liraglutide is the only one that has been approved with that indication right now. So this is kind of going to go over the trial immediately prior to the one that we're going to talk about. So subcutaneous semaglutide or Ozempic underwent testing for cardiovascular safety in what's called the SUSTAIN-6 trial. This was a randomized, double-blind, placebo-controlled trial, really testing the rates of a major cardiovascular event in Ozempic versus the placebo. So something important to remember as we look through these trials is they're not trying to compare, they weren't designed in a superiority fashion. They're not trying to say Ozempic is better than placebo for this outcome. They're looking at, the cardiovascular safety. So does this medicine increase a patient's baseline cardiovascular risk compared to placebo? They're trying to clear that hurdle that the FDA now requires, showing that it doesn't disproportionately increase a patient's risk. So something to remember about this trial is that the duration of the trial was driven both by the events and the actual time duration. So they wanted to accrue a certain number of events to make the study adequately powered, but they also had a minimum 104-week duration for their study because we know that a lot of times these medications, we don't see the side effects or anything until several months, years after they've started taking the medication. So essentially, the SUSTAIN-6 trial showed that Ozempic met the mark for non-inferiority as far as with respect to the composite outcome. So each of these trials we're going over is going to have kind of the same composite outcome, meaning they looked at cardiovascular mortality, non-fatal MI, non-fatal stroke all together and compared the rates of essentially all of those outcomes. So it met the bar for non-inferiority, and technically they run superiority testing on it once it meets that bar, which shows us that it may be statistically significant for superiority as well, but the trial wasn't really adequately designed to test superiority, so I don't think we can really take that as gospel. Something interesting is that the only individual component of each of those that make up the composite that was really statistically significantly reduced was non-fatal stroke. And that's something that we've also seen recently in the Rewind trial with dulaglutide or Trulicity. Both of those show reduction in non-fatal stroke as the main thing that's driving that composite outcome. Whereas with like liraglutide or Victoza, you see that reduced primarily because of a reduction in cardiovascular mortality. Something that's important that we'll get to is there was a higher incidence of retinopathy in the semaglutide group. So in the Pioneer 6 trial that I'm about to talk about, they excluded patients with active diabetic retinopathy because there was that higher incidence. This is thought to be similar to when you start somebody on insulin. You have just such a rapid reduction in blood sugar and in hemoglobin A1C. We know that that can worsen diabetic retinopathy. So this effect is thought to most likely be similar to that with Ozempic. So with any trial, with any new drug that comes out on the market, we always want to ask, why are they bringing this drug to market? Why do we need this? Something that we talked about earlier is up until now, all of the GLP-1 agonists are injectable medications. A lot of patients that you're going to try to start on those sometimes are really hesitant to start any sort of needles, any sort of injections. So having a PO option, a pill that they can take, can really help overcome some of those barriers and potentially allow us to start patients on a GLP-1, which we know are great for glucose control, they're great for weight loss. We may be able to start them on that earlier, having a PO option. And of course, they had safety data that the FDA requires for that sub-Q semaglutide or Ozempic, but they didn't have it for the PO medicine. So that's why they proceeded with testing in Pioneer 6. So essentially this trial, like we talked about, was a cardiovascular outcomes trial specifically designed to rule out an 80% excess cardiovascular risk. So remember, as we're looking through this, they didn't put the semaglutide versus placebo with an intention to find out that one was better than the other. They wanted to prove that semaglutide was non-inferior to a placebo with respect to increasing a patient's cardiovascular risk. So something a little different in this trial versus the SUSTAIN 6 is that it was event-driven but not time-driven. So they continued the trial until they got at least 122 events of the primary outcome. There was no minimum duration. So you'll see that this trial was actually quite a bit shorter than some of the others that we had previously shown, which obviously can potentially affect our results. So they selected patients with really high cardiovascular risk. So that's patients with diabetes who are either over 50 with known ASCVD or chronic kidney disease, or over 60 with cardiovascular risk factors. So that might include hypertension, hyperlipidemia, tobacco use, microalbuminuria, or proteinuria, things like that, that might make that patient at higher risk. So a little bit more about we kind of already talked about the inclusion criteria. The major exclusions were if they had already been on a GLP-1 or a DPP-4, which we know kind of works in a somewhat similar mechanism, within 90 days. Nobody with NYHA class 4 heart failure. If they had any planned revascularization procedures, they were excluded. Anyone with a recent, so within 60 days, MI, CVA, or hospitalization for unstable angina or a TIA. Excuse me. They also excluded patients who are on dialysis, which I think is something just to consider because, or with severe renal impairment, which is, I mean, that's a big one. That's a large proportion of patients with diabetes that wind up on dialysis. So it really would be kind of nice to know if this is something that would be safe to use in our hemodialysis patients with regard to their cardiovascular risk. And as we talked about, patients with retinopathy or maculopathy who were actively undergoing treatment. So overall, these are kind of the characteristics, the groups were pretty well matched. Something I did think was interesting is that about 72% of the participants in the trial were white, only 8%, I believe, African American, which is maybe a little bit different than the population that we typically see and take care of. Granted, this trial was conducted over several different countries. I think it was 30% Europe, 34% North America. So that may kind of affect their enrollment in the trial, but I did find that interesting as more and more we're talking about racial disparities in medicine and healthcare, that there wasn't, a higher proportion of African American patients in the trial, since we know that historically they're at such high risk for diabetes and associated cardiovascular disease. So there were about 3,000 patients that were selected. They either got a once daily semaglutide, the target dose of that being 14 milligrams, or a placebo pill. They did kind of dose escalate with semaglutide, just like we do with the sub-Q, to try to decrease GI side effects. They did this in addition to quote unquote standard of care treatment. And I don't know that any of us really know what that is. I couldn't find anything in the article or in the appendix. There wasn't anything specifically said about what was and wasn't standard of care. I've kind of highlighted here, they basically gave the investigators free rein to change the patient's existing diabetes therapy and cardiovascular medication throughout the trial. And that wasn't really standardized in any way. They just said to do it in accordance with guidelines. So that's something that I think might, affect our results as we move through it. So their primary outcome, again, was a composite outcome. So time from randomization to the first occurrence of a major adverse cardiac event, meaning death from cardiovascular cause, non-fatal MI, or a non-fatal stroke. They had an expanded composite outcome consisting of the primary outcome plus a hospitalization for unstable angina or CHF. And then another composite of all-cause mortality, non-fatal MI, non-fatal stroke. And then they also tested additional efficacy outcomes, basically just checking the change in A1C, body weight, lipids. But again, that wasn't the primary focus of this trial. They also checked any adverse events that led to discontinuing the medicine, quote unquote, serious adverse events. And then they also kept track of the special interest adverse events, being retinopathy or severe hypoglycemia. They did the statistical analysis consisted of an intention to treat analysis with a stratified Cox proportional hazards model used for their primary outcome analysis. And then similar to the previous trial, after they confirmed non-inferiority of the primary outcome, they did perform superiority testing as well. But just important to remember, that's not really what the trial was designed for. So total, there were just over 3,000 patients. The median duration of the trial and follow-up was 15.9 months. So remember, some of those other ones we looked at were quite a bit longer. The LEADER trial, which was the one with Victoza, which is kind of, the one medicine that's actually has a cardiovascular indication in this class, was I think 3 or 3.8 years. The REWIND trial, which was recently published with Trulicity, was over 5 years. So this was really quite a short time, which makes me think they may have been kind of trying to accrue enough events to get their approval to try and get this drug on the market. And you can see here, of the patients that completed the trial and finished it, those 15.9 months with semaglutide that hadn't discontinued it, about 1,100 of them were up to that 14 milligram dose. So most people that took it were able to get up to that maximum dose. Just really quickly, kind of the baseline therapy. This is what patients were on at the beginning of the trial, in addition to either the semaglutide or placebo. Interesting that only about 9%, closer to 10%, were on SGLT2 inhibitors. We still got 32% of people on sulfonylureas, which makes me want to rip my hair out a little bit. But something else to keep in mind is more patients either initiated or intensified additional glucose lowering therapies in that placebo group, which makes sense. And they specifically had quite a bit higher use of SGLT2s or starting of SGLT2s in that placebo group. And remember that we know that those decrease cardiovascular outcomes. So getting to the results in the primary outcome. So in the treatment group, or the semaglutide group, they had 61 patients experience that primary outcome, 76 patients in placebo, which correlated to about a 21% difference in risk. So something to remember too is that they're reporting all of this in terms of hazard ratios, which is different than our actual risk ratio. So something I was kind of reminded of when going through this trial and kind of prepping is, investigators can be very selective about the way that they report their results. So that hazard ratio of 0.79 or that range shouldn't necessarily correlate in your mind with like a 21% difference as far as a risk ratio. But it did confirm non-inferiority. You can see that range of that confidence interval does cross over 1. So it confirmed non-inferiority. Again, when they went back and ran the superiority testing, you can see it's not statistically significant. But again, the trial wasn't really designed that way. So we can't take that as gospel necessarily. A couple things that are interesting. So in SUSTAIN 6, with the sub-Q form of the same medicine, we talked about how the primary outcome that they met was driven mostly by a reduction in non-fatal strokes. And in this trial, the biggest reductions that they saw were actually in cardiovascular death and all-cause mortality. There wasn't really a difference in non-fatal strokes or in the expanded outcome. There was actually a slight increase in non-fatal MIs, not statistically significant, but just kind of goes to show again that we don't really know, we can't really say that the GLP-1s have a class effect since they have, so many different areas that we're seeing these improvements in. So you can see kind of just on the chart with the composite primary outcome, you can see the rates of events with semaglutide being much lower, and then as well as with death from cardiovascular cause, but MI and stroke, we don't really see much of a difference. Surprise, hemoglobin A1C levels reduce more in the patients on a diabetes medicine than on placebo. I don't think anyone should actually be surprised by that, but again, their efficacy outcomes showed us that they also had a greater reduction in body weight. Systolic blood pressure was a little bit lower, LDL and triglycerides somewhat lower. The mean pulse rate for patients did increase by about 4 beats per minute, and that's pretty consistent across the other studies that have tested cardiovascular outcomes in patients with GLP-1s. So there were they said serious adverse events, 301 in the treatment group and 358 in placebo. These were listed most commonly under a cardiovascular event or an infection of some sort. There was a pretty significantly higher risk of discontinuing the semaglutide versus placebo, and this was primarily driven by GI intolerance, which is something that I think is pretty well established with these medicines. And we've kind of learned, it seems like they have this effect whether it's given sub-Q or PO. As far as the retinopathy, there really wasn't a statistically significant difference in patients who developed retinopathy. Remember, at the beginning, they excluded any patients who had active retinopathy or maculopathy, so these were new cases. Most of these were non-proliferative, and they were identified just during a routine screening exam. The patients weren't symptomatic, and 75% of the cases resulted in not needing any new treatment for it. There was a higher rate of hypoglycemia with the semaglutide versus placebo. All of these events occurred in patients also receiving insulin or a sulfonylurea. Again, just another reason not to use sulfonylureas. But this is, again, something that we know we always have to be mindful of when starting patients on a GLP when they're also taking insulin. There was one case of medullary thyroid cancer in patients receiving the oral semaglutide, and that patient was noted to have pre-existing thyroid nodules and an elevated calcitonin level at baseline. So all in all, this trial met their primary objective of ruling out an excess cardiovascular risk. They met the barrier that the FDA puts out to confirm that new meds aren't going to put patients at a disproportionately higher risk of cardiovascular events. So this is pretty consistent with the other cardiovascular outcomes of GLPs. It didn't really confirm superiority as some of those other trials have done, like we said, but again, it wasn't really designed to do that. And something that I think may have particularly affected this is it had much fewer patients, not necessarily in SUSTAIN 6, but the LEADER trial with Victoza had, I think, over 9,000 patients, so 3 times what this trial did. And the duration, as we've already talked about, was much shorter. So our data, could have looked wildly different, as with any trial with a larger patient population, and particularly with a longer duration. The positive result in this trial was really driven by a decrease in cardiovascular and all-cause mortality, which is, important to kind of keep in mind, since some of those other GLPs have really met that mark by decreasing non-fatal stroke. So some of the things just to kind of talk about when we look at this trial critically is we still really don't know how the GLPs really affect the cardiovascular system and cardiovascular risk as a class, because the benefits and the positive results we're seeing from all of these trials are really driven by different outcomes. They may all have, a positive result in regards to that composite primary outcome, but some of them are reducing risk of cardiovascular death. Some of them are only doing non-fatal stroke. So I really think we just need more data, longer trials to get a sense of really how this is happening. Something that I think may have potentially kind of skewed those results is that, like they said, patients were receiving additional medications for their diabetes. This wasn't really standardized in any way. There were more patients on an SGLT2 in the placebo group versus the treatment group. Like I said, these have been now pretty well established to reduce cardiovascular disease. So could that have even skewed the results a little bit in favor of placebo? It's really kind of hard for us to tell. And something else that was interesting is the majority of the patients in this study, right at about 85%, were in that group that was greater than 50 with established cardiovascular disease. And more these days, we're looking at how can we potentially use these drugs for primary prevention. I have a typo there, of cardiac disease in these patients. So it'd be interesting to see one of these done with more of those patients in that risk factors only group to see if we get the same effect in terms of primary prevention. So some things that we can consider clinically in this case is, I think this is really huge in that this medicine, that trade name, I don't know if I mentioned it earlier, is Ribelsis. This really gives us a new option in the GLP-1 class for patients who are hesitant to start these injectables because of the fact that they're injections. It may let us start this medication earlier than we normally would because we're able to use a PO option instead of a sub-Q injection. Like I said earlier, I do think we really need just maybe longer studies specifically designed to look at superiority in those patients with cardiovascular risk factors to see if we really do see consistent reductions in cardiovascular risk. This study that we just talked about showed us that it's non-inferior to placebo with respect to cardiovascular risk, but overall, I think we need to see it used in for a longer period of time and have that data to see whether or not this truly can help us reduce risk or not. And something else I wanted to mention that I didn't really know where else to throw in is all the things I read about the GLPs is that there seem to be different mechanisms for how the cardiovascular risk reduction works versus the SGLT2s. With those medicines like Jardiance and Invokana, they typically saw an improvement in things like heart failure hospitalizations much sooner than they saw benefit in the GLP-1 trials. And the benefits there are thought to be due to effects the SGLT2s have on hemodynamics. The fact that it kind of takes longer to see benefit with the GLPs makes a lot of people postulate that they probably have an anti-atherothrombotic effect, which explains why we really need these studies to be longer than the 15 months that this one was. So something I just wanted to touch on really quickly is what are pre-approval, or rather accelerated approval outcome studies. So most people, it seems, are trying to move away from the pre-approval label and really call these accelerated approval studies. So these are an intervention that's treating a serious or life-threatening disease that can receive an accelerated approval based on a trial that shows a positive effect in surrogate measures. So surrogate measures are things like labs, physical findings, vital signs that can serve as an indicator potentially of a clinical outcome. So think of a hemoglobin A1C or an HIV viral load, but aren't 100% related to a specific clinical outcome like mortality. So essentially, these drugs can be approved faster than what it would typically take based on, if they can show that they improve A1C or viral load or something like that. rather than taking, the extended time it would need to run a trial to test something like mortality. Once these drugs are approved, the FDA requires a confirmatory trial to be completed within 3 years, kind of verifying this efficacy, and then the label is changed to a regular approval. So some of the issues with this that we need to keep in mind, because we're seeing more and more of these trials now, these trials are usually smaller in patient size or shorter. So this could potentially pose a greater safety risk to patients because we don't have as much verified data as with maybe a medicine that went through the regular approval process. You have to be careful about what surrogate measures were selected by the investigators because they may or may not actually materialize into a mortality benefit or clinical improvement. Sometimes when these meds are put out on the market, they can start being used frequently and widely very quickly, even though they were launched on kind of limited evidence. So I think with these trials in particular, we really need to look critically at what surrogate measures are they selecting. Is that something that we really see turning into a clinical benefit in our real practice? Another kind of issue that I found with these types of trials is sometimes those confirmatory trials that are done, a year or two after the accelerated approval are still tested on, those same surrogate endpoints that can be used to get accelerated approval. So they may not even necessarily be looking at mortality or something else. For example, if it was a diabetes drug, they could have used an improvement in A1C to get their accelerated approval, and then with their confirmatory trial, still just use A1C without really looking at anything different. And really something to keep in mind with these surrogate endpoints when you're looking at an accelerated approval trial is, does this endpoint they used actually fall kind of within the same causal pathway when it comes to the progression of the disease process? So A1C with regards to diabetes is a pretty good example. We see that when patients have really high A1Cs, they develop complications faster and they have a low or a higher rates of mortality, similar to a viral load in HIV. So you just have to be mindful of what surrogates exactly that they're using and whether or not those are actually going to be helpful to you in clinical practice. These are my references. And I have a few pictures for you guys. Up in the top left is Dr. Hebert drinking coffee out of a glass beer mug like an animal. Some of the beach pictures are from my husband's and my trip to Key Cocker in Belize over Thanksgiving, which was absolutely beautiful. I have some pictures from the Christmas party, and then when Trace and I went to Red River right before Corona hit to do some skiing and snowboarding. And then down in the middle is really the only publicly acceptable photo I have of this last weekend and our graduation party. It's just one of our goofy group photos. For the full account of the weekend, you can check out my Instagram. It's all still there, but nothing else PowerPoint worthy. Thank you guys, and let me know if you have any questions at all about the trial.